Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject on pediatric surgery made easy. This subject is very important for all pediatric surgeon and pediatrician. Let's start. Our subject today is about intussusception, which is a very common cause of acute abdominal emergency. It's very important for pediatric surgeon and pediatrician, so we will illustrate and we will explain all the details related to this important disease. Our ILOs will be related to what is the pathophysiology of intussusception, what regard primary and secondary types of intussusception, and how to diagnose this problem, how to treat, and then we will speak about special types of intussusception regarding the recurrent and the post-operative and chronic intussusception. Let's start. Intussusception. What's meaning of intussusception? It is acquired invagination or telescoping of the bowel. Part of the bowel is invaginated or telescoped into another part. So we have a proximal bowel, like the terminal ileum, and the distal bowel, like the ascending colon. So the proximal bowel will be telescoped or invaginated into the distal bowel. As you see in this picture, the proximal bowel or the terminal ileum or the ileocecal part telescoped into the cecum, as we see, and folded upon himself inside the distal bowel. So this telescoping or invagination is called intussusception. And the part of the bowel, of the proximal bowel inside, is named as intussusceptum. And the outside part or the distal bowel is called intussuscepium. So we must understand this simple terminology. The process itself is called intussusception, which means that proximal bowel telescoped or invaginate into the distal bowel. The part inside is called intussusceptum. You can remember that the septum is inside, and the outside part is called intussuscepium, which is the container. So this is intussuscepium, the outer part, and the inner part is called intussusceptum. It's one of the most common causes of acute intestinal obstruction in children. Early diagnosis and prompt trial at the reduction dramatically improve the clinical outcome. The incidence is about 1 to 4 in every 2,000 children worldwide. Usually intussusception affecting well-nourished, healthy infant, and about 2/3 are boys. The highest incidence occur in infants between 4 and 9 months, and it is the most common cause of the small bowel obstruction in this age group. Intussusception is uncommon below the 3 months and after 3 years of age. However, the condition described in the premature infants and may be suggested as the cause of the bowel atresia in some cases. As we see in this picture, there is telescoping or invagination of the proximal bowel segment into the distal bowel segment. The intussusceptum is included inside the intussusception, which is the outer part. With regard to localization, within the gastrointestinal tract, we can find that the most common is the ileocolic type. The most common is the invagination or telescoping of the terminal ileum into the colon, which is called ileocolic. Ileo meaning that the proximal part is the ileum, invaginate into the colon. So it is called ileocolic. Other forms may be ileoileal, which means that the ileum invaginates, one segment of the ileum invaginate into the second or another segment of the ileum, and also cecocolic and colocolic and jejunal intussusceptions or types of intussusception. However, the most common is the ileocolic. Pathophysiology. What happened? Normally, peristalsis is present, pushing the food content inside the bowel from proximal to distal. Normally, there is no way for intussusception. The bowel is contract proximal and the distal relax. Then the another segment contract and followed by relaxation. So what happened? The proximal bowel telescope or invaginate into the distal bowel by the peristaltic activity. As we see, this is the proximal telescoping or invaginating into the distal part of the bowel. There is may or may not be a leading or starting point. So we may have starting point for this telescoping or invagination, or sometimes we may not find any starting point. Like the picture of the telescope. As we see this picture, the telescope formed of different segments, each one can be telescoped over each other. So this is intussusception. The mesentery of the proximal bowel, as we see here, this is the mesentery supplying the proximal bowel, is also drawing into the distal bowel, as we see, resulting in a venous congestion and mucosal bleeding, and finally maybe bowel wall edema. So this invagination or telescoping not only taking the wall, they also taking the wall with its supplying blood vessels. So if reduction doesn't occur, arterial insufficiency and ischemia and maybe bowel wall necrosis. So it's very important for the pediatric surgeon and pediatrician for early recognition, diagnosis, early attempt or trials at reduction to save the intestine of the baby or the child. It's very important, as the pathophysiology will include venous obstruction followed by arterial obstruction and ischemia. Transient intussusception probably may quite happen with normal peristalsis. However, they recovered spontaneously. Some authors document that sometimes may be transient intussusception of the bowel and that they are relieved spontaneously. However, the natural history is to progress to the bowel ischemia and necrosis unless recognized and treated very early. So it's very important to understand this. Delayed cases may show systemic metabolic alteration due to prolonged intestinal ischemia. Even after successful reduction, the systemic hypovolemia and shock may follow after what's called reperfusion syndrome. Reperfusion of the ischemic bowel may cause systemic overflow of the vasoactive metabolites with subsequent systemic hypovolemia and maybe subsequent shock. So it's very important not to be delayed for the diagnosis and the treatment of this serious condition, as delay in the diagnosis may lead to systemic hypotension, subsequent shock in some children due to reperfusion syndrome, like what happened or reported in the lower limb. If the blood supply is cut or prevented over a limb or a bowel, then with reperfusion, we may have what is known as reperfusion injury or reperfusion syndrome, sudden release of or overflow of vasoactive metabolites. Etiology. One must ask, what's the cause? Why proximal bowel telescoped or invaginated into the distal bowel? If there are etiology for this, etiology is present to explain this problem, we may have two types. Pediatric intussusception generally and usually idiopathic, unlike adults, with no identifiable lesion. This is the majority and the called primary intussusception, or sometimes idiopathic intussusception. The proximal bowel telescoped into the distal without identifiable lesion, without lesion in the bowel wall. About 10% of cases may have a lesion, which is called secondary intussusception. This lesion in the bowel will act as a leading or starting point for intussusception to occur. So this lesion inside the lumen or in the wall of the bowel may be felt by the bowel as food bolus, may be felt as a content and the bowel trying to push it forward during peristalsis. So the presence of this lesion is called leading point or sometimes starting point for intussusception, and cause the proximal bowel to invaginate or telescope into the distal bowel during normal peristalsis. So we have two types, the primary intussusception and the common idiopathic with no identifiable lesion. And there was a secondary intussusception. In about 10%, we may have a starting or leading point in the intestine, which will act as the start point for intussusception to occur and for the invagination to happen. So we will start with the primary or idiopathic intussusception. This is the majority of the cases and usually seen in infants. Several predisposing factors may be suggested to explain what happened. Number one, some pediatric surgeons document that infectious etiology is the cause for the primary intussusception, or maybe anatomic defects in the developing gastrointestinal tract, or maybe abnormal or altered peristalsis in the bowel wall, or maybe functional bowel disorders and some poorly understood neuroenteric disorders. So these are the predisposing factors trying to explain why primary or idiopathic intussusception happened. What is the etiology? This is some supposed or suggested theories trying to explain this abnormal process of invagination or telescoping. Infectious etiology, the most common one, often caused by viral illness affecting the infant, like upper respiratory tract or viral gastroenteritis. This viral infection and this viremia will stimulate the gut lymphoid tissue and causing enlargement and edema of the Peyer's patches around the terminal ileum. This enlarged lymphoid tissue in the gut may act as the leading or the starting point for intussusception to start or to occur. So this is one explanation is a viral infection and viremia, like upper gastrointestinal or gastroenteritis. And usually when you are going to take a history from the mother, they document that the baby after the attack may have an attack of upper respiratory tract infection or may have a gastroenteritis previously before the development of the intussusception. Evidence contribute that the viral infection may play a role include number one, adenovirus, and to less extent the rotavirus may be historically implicated in up to 50% of cases. This is number one. Number two, there is documented rise in the intussusception cases during seasonal respiratory viral illnesses. So during seasonal respiratory virus illnesses, you suspect to see more and more cases of intussusception. So the link may be related to viremia and enlargement of the Peyer's patches, which will act as a starting or leading point. Also, documented increased intussusception risk with rotavirus immunization. So all these items or evidence contribute that the viral infection may be related to the primary or idiopathic intussusception. In the USA, initial rotavirus vaccine was removed from the market due to significant increase in the incidence of intussusception. However, the present immunization today available in the USA also have been associated with a small risk. However, when you weigh the risk of the intussusception and on the other hand, you put the benefits of the vaccination, sure, the benefits of the vaccination will widely outweigh this risk. So you will give the vaccination to the child or to the infant and follow up these children to die for early diagnosis. So you cannot stop vaccination for the fear of the intussusception because the benefits of the vaccine is obviously more and more and widely outweigh the risk of the development for intussusception. Number two, the second theory or the second predisposing factor is some anatomical defects in the developing gastrointestinal tract. Some authors suggest that there is maybe abnormal insertion of the terminal ileum with respect or in relation to the cecum. So this abnormal insertion facilitates the development of intussusception. Number two, some authors described decreased rigidity of the cecum, secondary to absent or underdeveloped Taenia coli. So the cecal wall is soft, not rigid. So it's very easy for the terminal ileum and to invaginate into this weak or abnormally developed cecal wall. Number three, there is maybe also lack of the mature longitudinal muscle fibers of the colon, lack of the developed Taenia coli at the level of the ileocecal valve. This abnormal anatomical structure may explain the occurrence of the primary or idiopathic intussusception. Number three, there is maybe altered peristalsis in the bowel wall. We mean that we may have a focal areas of aperistalsis, area in the bowel don't move. So this area will be faced by the proximal peristalsis, and this aperistaltic segment may be pass or feed into the peristaltic areas surrounding them, leading to the telescoping or the formation of intussusception. Also, some functional bowel disorders and some poorly understood neuroenteric disorders, like what's called small intestinal pseudo-obstruction, can alter the peristalsis and result in the intussusception by the same manner like aperistaltic segment and peristaltic segment. So this aperistaltic segment may form the leading or the starting point of intussusception. This is regarding the primary type, which is called primary intussusception or idiopathic intussusception. No cause. However, pediatric surgeon trying to explain what happened, they suppose maybe infectious etiology and viremia with enlargement of the Peyer's patches. There may be abnormal anatomical defects. They may be affection of the peristalsis. They may be functional bowel disorder and some neuroenteric disorder. Pediatric surgeon must understand this series, trying to explain what is the etiology for the primary intussusception. Secondary intussusception is an intussusception as a result of a specific anatomical or pathological leading point. Here, there is a cause. There is a lesion which acts as a leading or the starting point, drawing the proximal bowel into the distal bowel by the peristaltic activity. Incidence between 2 and 12% of all cases. Incidence found to increase with age and should be suspected if you and should be suspected in a child who present outside the normal range of age for intussusception or a child who has multiple episodes. This is a secondary type of intussusception. What are these leading causes? Or what are these leading points that may cause secondary intussusception? The most common is the Michel's diverticule, and sometimes polyps or duplications of the gastrointestinal tract. Sometimes the leading cause may be the appendix, some hemangiomas, carcinoid tumors, foreign bodies, ectopic pancreatic or gastric tissues, hamartomas, or some syndromes may be the cause, may be the leading point for intussusception. Malignant causes, although rare, increase in incidence with age and include lymphomas and small bowel tumors. We may have some systemic diseases like cystic fibrosis. Cystic fibrosis, how cystic fibrosis causes intussusception? The sticky or abnormal and insipid fecal bolus and feces adherent to the intestinal mucosa sought to act as the leading point in the ileum, causing ileocolic intussusception. Sticky bolus or sticky or insipid stool bolus and the intestine trying to push these sticky bolus so they will be telescoped and invaginated into the distal adjacent bowel. Sometimes what's called perbra, some types of perbra, IgA vasculitis. There is maybe intramural hemorrhage or inflammation within the mucosa sought to act as the leading point for the intussusception, usually small bowel to small bowel intussusception. So these aggregations or this hemorrhage may make swelling or may lead to hemorrhage and inflammation in the intestinal wall. This will be act as a leading point like Peyer's patches hypertrophy. So the intussusception will start over it. Other diseases like celiac disease, Clostridium difficile colitis, or intestinal allergies and Crohn's disease. How or what is the mechanism? By hypertrophy of the Peyer's patches or mesenteric lymphadenopathy. So in all these diseases, this will act as a leading point. We speak about the secondary intussusception. There are leading cause in the bowel wall. Malrotation, yes. Intussusception may be associated with malrotation in a condition called Wa syndrome. What happened? This is association between two items, malrotation and intussusception. Wa syndrome is the prolapse of the ileocolic into the non-fixed ascending colon in the children with malrotation. We know that in a malrotation, the ascending colon is not fixed in the proper position and present in the mid-abdomen. So in these babies, the ileocolic will invaginate into this non-fixed or abnormally located ascending colon, presented with acute bowel obstruction, bleeding rectum, and sometimes with a transanal prolapse of the intussusception. The intussuscepted mass will pass through the ascending colon, transverse colon, descending, and also prolapse it outside the anus as prolapsed intussusception. Wa syndrome. Because the ascending colon is not fixed, as we see, to remember that in a malrotation, the ascending is present in the mid-abdomen, not fixed to the retroperitoneal, so the intussusception often advance through the descending rectum with a transanal prolapse of the intussusception and sometimes without compromising the vascularity of the bowel. At time of surgery for intussusception, the diagnosis of malrotation usually confirmed by the location of the cecum and the presence of the peritoneal band or lap bands across the duodenum. But the problem here is that almost all cases of intussusception are managed with non-surgical reduction, hydrostatic reduction. So in Wa syndrome, you will manage the baby with hydrostatic reduction, so the malrotation will not be diagnosed. You will manage this child. Let's see. As a non-operative reduction is the common practice for the pediatric intussusception, pediatric surgeon should be aware of the possibility of Wa syndrome in a cases of recurrent ileocolic intussusception. Number two, child present with transanal prolapse of intussusception. So in both conditions, you must be aware that the case may be Wa syndrome, which means that intussusception associated with malrotation, which need operative correction of malrotation and also corrections of intussusception. Clinical presentation. Patient may present with abdominal pain, very common, intermittent, cramping pain with characteristic pulling up of the legs to the abdomen in a child previously free of symptoms and comfortable and usually following episodes of viral infection, as we says that there is maybe viral infection in the upper respiratory tract or gastroenteritis. So this is the first thing, is abdominal pain. There is maybe bilious emesis, yes, with increasing abdominal distension, and the normal bowel movement will stop as the obstruction progress. Intussusception is one of the causes of the acute bowel obstruction. The intussuscepted mass will obstruct the lumen and will cause intestinal obstruction. And lately, the child may present with what is called red currant jelly stool, which indicates that there is a bleeding and sloughed mucosa. Abdominal pain, the first, usually sudden, and the child may stiffen and pull legs up to the abdomen, can be associated with hyperextension, breath holding, or vomiting. Pain attack usually stops suddenly as it started suddenly. Between attacks of pain, the child may appear comfortable, but eventually will become lethargic and exhausted from the dehydrations, vomiting, crying, excessive pain. Bilious emesis, as we see, there is an obstruction of the lumen with the dilatation of the proximal bowel and abdominal distensions, as the normal bowel movement will stop as the obstruction progress. So the child present with a bilious emesis. Red currant jelly stool. Stool may be blood tinged as impending ischemia called mucosal sloughing and compression of the mucous gland leading to evacuation of the dark red mucoid clots or currant jelly stool, often a late sign. The pediatric surgeon never wait the presence of these signs. Intussusception must be diagnosed very early to save the bowel, to save the condition of the bowel by taking good history from the mother, history of viral infection usually present, preceding the attacks of abdominal pain, the bilious emesis, and during examination you will find the mass. So there is maybe triad of a pain of the bilious emesis or finding mass in the abdomen during examination. So a risk is to wait for the current red jelly stool, leukocytosis, or electrolyte abnormalities that are often the hallmark of ischemic bowel. During physical examination, it's very important that the child vital signs are usually normal early in the disease course. However, there may be signs of dehydration or septicemia in the form of tachycardia and fever in delayed cases. Also, sometimes in neglected cases, the child may present with septic shock. So there is extreme of presentations from early presentation and late or neglected cases and presentation with shock or sometimes with tachycardia and fevers or septicemic manifestation. On physical examination, pediatric surgeon may elicit palpable abdominal mass, or what's called sausage-shaped or curved mass, might be palpable anywhere in the abdomen, even visualized if the child is very thin. This is the mass, sausage-shaped or insipid mass present in the abdomen, anywhere or maybe even visualized. Number two, what's called dance sign or sign of dance. Flat or empty right lower abdominal quadrant as the intussuscepted mass is drawing up into the transverse colon. The terminal ileum or push the cecum and go to the transverse colon, so the right lower quadrant will be empty. And this is called dance sign or sign of dance. It is due to progression of the cecum ileocecal into the right colon. As we see here, there is progression of the mass into the transverse colon, and so the right lower quadrant of the abdomen will appear empty. Number three, which is a grave sign or dangerous sign, is a prolapsed intussusception. Occur with disease progression or delay in the diagnosis, the intussuscepting mass prolapse through the anus, which may be also ischemic. Great danger is to misdiagnose prolapsed intussusception as a rectal prolapse. And you are going to try reduction of rectal prolapse. However, you must remember that Rectal prolapse is not associated with vomiting or sepsis. The presentation is different between intussusception and rectal prolapse. So it's very important for the pediatric surgeon to differentiate prolapsed intussusception and rectal prolapse. How to differentiate? Very important. Careful physical examination is mandatory and can be done by inserting lubricated tongue plate or gloved finger along the side of the protruding mass. If the blade or the gloved finger can be inserted more than 1 to 2 cm into the anus along the side of the mass, the diagnosis of intussusception should be considered. So the differentiation will depend on that the rectal prolapse is prolapsing at the level of the anus, so will be all layers prolapsed down. However, in intussusception, there is mass from inside. So if you can insert your fingers more than 1 to 2 cm into the anus along the side of the mass, beside the mass, the diagnosis of intussusception should be considered to save the bowel of the baby, and don't perform trials of reduction as you diagnose the case as rectal prolapse. Beside the history of the viral affection usually present, the age of the baby, the presence of abdominal pain, sausage-shaped mass, sign of dance, all these manifestations will direct the pediatric surgeon for diagnosis of intussusception. Also, rectal prolapse, also not associated with vomiting or sepsis. This is not a manifestation of the rectal prolapse as we mentioned in the session of rectal prolapse. Investigation. Plain X-ray, usually non-specific, and may have normal appearance. However, sometimes they may show littlety of gas or rarity of gas, possibly in the right iliac fossa. However, sometimes feature of the small bowel obstruction, dilated gas-filled lobes, or soft tissue mass shadow of intussusceptum may be seen. Sometimes, however, usually non-specific. To diagnose intussusception using a plain X-ray. Ultrasonography is the gold standard today in the diagnosis, with a sensitivity and specificity reaching about 100%. Most centers use ultrasound as a screening tool due to lack of the radiation exposure ability to identify the pathological lead point and also low cost. However, ultrasound is operator dependent and need an expertise in doing ultrasound. Screening ultrasound in the hands of the expert person is highly accurate, decrease the number of unnecessary contrast enema reduction, decrease exposure to the radiation, ionizing radiation, differentiate between small bowel, ileoileal, and ileocolic intussusception. What's the characteristic finding of ultrasound? Number one, what's called target sign. Target sign, we mean by target sign, alternating rings of the low and high echogenicity representing two things, bowel wall and the mesenteric fat within the intussusceptum, the part inside, in the transverse plane. So this target sign is the first characteristic finding of on ultrasound examination called target sign or target lesion. Pseudo kidney sign seen on the longitudinal section secondary to edematous wall of the intussusceptum within the intussusception. Intussusceptum is the part inside edematous wall, and the outside container is called intussusception, as we said in the start of the presentation. So this is called pseudo kidney, like kidney shape, pseudo kidney sign in the longitudinal section. It's very important, the target lesion, the pseudo-kidney sign, and also ultrasound may show the presence of the free intra-abdominal fluid, bowel vascularity, if we used colored Doppler by the wall edema and the peristalsis, we can comment on the bowel vascularity. We can suspect impending affection on the bowel vascularity and that need urgent surgical intervention. So it can indicate if the surgery is the more appropriate rather than image-guided reduction, if there is a compromised bowel involved. So ultrasound is the gold standard, very important to diagnose intussusception. What's called interloop fluid is the fluid seen between the two parts, the inside and the outside part, between the intussusception and the intussusceptum, is associated with increased failure rate of pneumatic or air reduction. So if we see interloop fluid, this is a sign documented by the ultrasound. This means fluid between the two parts, intussusceptum and intussusception. If there is a fluid, this is associated with increased failure rate of the air reduction technique. Also, lymph nodes is a common finding, usually reflection of the underlying inflammatory process, but may represent the lead point, especially if associated with mucosal thickening. So ultrasound can comment on hypertrophied or enlarged lymph node. This lymph node enlargement may indicate two items, whether inflammatory process or maybe also act as the lead point for the start of intussusception. What is the role of CT and MRI? Neither CT nor MRI is routinely used in the evaluation of intussusception. The decision to perform this sophisticated investigation should correlate with the clinical features of the child. CT can be done in older child outside the normal range for the primary or idiopathic intussusception. So in secondary intussusception, yes, we may use the CT searching for the cause, especially if there is irregular feature or the diagnoses are not clear, associated pathology as lymphoma, which need to be investigated. Also, the CT may show evidence of intramural hematomas. So this is the rule for the use of the CT and MRI in diagnosing cases of intussusception. Management. How to manage? You are the pediatric surgeon on call and you see a case of intussusception. What to do? The first line management in all cases is intravenous resuscitation, nasogastric insertion to decompress the stomach, CBC and serum electrolytes. However, there is a debate that there is no need for routine antibiotic administration. And the third items, you must reduce the intussusception or relieve the intussusception. So your first line management and resuscitation will depend on the condition of the baby. Whether the baby came to you in an early stage of the disease course or came with a late metabolic disturbance or even with septic shock. So resuscitation will depends on the presentation of the child. So you may need to do an aggressive resuscitation. You may do an aggressive repletions of the fluids in a severely dehydrated infant or child. Regarding reduction, what we mean by reduction? We mean that we reduce the segment or we relieve this telescoping or invagination. We can perform this action whether using radiologically guided reduction or operative or surgical reduction. So we may use radiological guided reduction or surgical or operative reduction. Radiologically guided is less invasive. So it seems logic that we start with the radiologically guided reduction. Once the diagnosis is confirmed, the child would normally proceed to the radiological reduction with air or contrast enema under fluoroscopic guide if there are no contraindications, as intestinal perforation or free intraperitoneal air, if there is no peritonitis or persistent hypotension and septic shock. So if there is contraindication, you will go to surgery. However, most centers today use an air reduction enema as the first line treatment. So once the diagnosis confirmed, the child would normally proceed for the radiological reduction, except if there is a contraindication for radiological reductions that necessitate surgical interference, as intestinal perforation, free intraperitoneal air, as a presence of the peritonitis or persistent hypotension. Radiological reduction usually performed under fluoroscopic guide. It's also possible to perform the reduction under ultrasound. However, fluoroscopy allows visualization of the whole abdomen and allow early detections of the perforation, but it uses ionizing radiation. Ultrasound, on the other hand, use no radiation but can only follow the head of intussusception, only follow the head. While using fluoroscopy, allow the pediatric surgeon to observe the whole abdomen and to diagnose early perforation if happen. Radiological reduction, very important, should be attempted only in the center with a pediatric surgery available and standby in case of complication, perforation, or unsuccessful reduction. So the reduction of intussusception must be performed in the centers where the pediatric surgeon present and available. So in case there is a perforation or complication happen, the pediatric surgeon can interfere. And the team for surgery must be standby with all equipment ready if radiological guided reduction is failed or unsuccessful or there is a complication. Very important. Radiological reductions usually not successful in ileoileal intussusception, older child, or a child with atypical presentation with secondary pathology, delayed presentation, certain features as a presence of the blood per rectum. Hydrostatic reductions. This is the first form of the radiologically guided reduction. At first, it was performed using saline under anesthesia. The essential basis of this technique were incorporated into the modern methods of the hydrostatic and also air reduction. As we see, this is the idea to inject contrast. This contrast will push the intussusceptum from inside the intussusception. So push the head, and after pushing, you will observe free flow of this dye into the small bowel, indicating relief of the obstruction. This is the main idea, and this was used for and modified in the modern techniques of hydrostatic and air reduction techniques. Today, hydrostatic reduction using barium or water-soluble contrast generally less used, and most centers use air reduction because it's safer, have a higher reduction rate, lower patient radiation dose. Water-soluble isotonic contrast, no doubt, is better alternative to barium owing to the risk of the bowel perforation. If bowel perforation happen, that there will be inflammation of the peritoneum. Means if we use barium, however, water-soluble contrast will be more tolerable and more better if perforation happen. Principle of the present hydrostatic reductions include that Foley catheter is inserted into the rectum and held by holding the buttocks together to create a tight seal to prevent leakage, and that water contrast run into the rectum from a height of about 3 feet, 91.44 cm above the patient. You must put this by the present above the patient to allow free flow without excessive pressure. Contrast hydrostatic pressure is continued as the reduction is occurring and the bowel feeling observed on the fluoroscopy. Usually reduction is seen until the ileocecal valve, with delay at that point until free flow of the contrast is seen into the distal small bowel. This delay usually due to presence of the edema around the ileocecal valve. So the contrast will pass from this height, feeling the rectum, rectosigmoid, and the descending transverse, and then reaching to the ascending colon until the area of the ileocecal there will be some delay owing to the edema present at that area. Then the reduction is successful if the contrast is freely flow into the distal small bowel. Successful reduction, as we see here, this is the arrest of the dye and followed by the passage of the dye into the small bowel. Successful reduction depends on the observation of the free flow of the contrast into the distal small bowel. If no progress, the contrast is drained and the procedure can be repeated up to 2 further times. So this is called the hydrostatic reduction using water-soluble isotonic contrast enema to disclose or to relieve the obstruction or to relieve this intussusception. The advantage of the hydrostatic reductions are the decreased morbidity, decreased cost, and decreased length of the hospital stay. Pneumatic reduction or air reduction, reduction using air injection. Most centers today use pneumatic reduction. Its use became the mainstay of the treatment after international reports of the large series of higher success rate. Air is insufflated into the rectum via catheter under fluoroscopic guidance. As we see, this is the mass of the intussusception marked by the arrow, and this is after the release and after the passage of the air into the distal small bowel. So this is called pneumatic or air reduction enema under guidance of the radiological guidance. Air enema reduction is more successful with a history of less than 24 hours of the presentation. However, history of more than 24 hours or absent colored flow on Doppler are not contraindication to try air reduction enema, but may indicate that the reduction may be difficult and should be undertaken with caution to avoid perforation or failure. So it's very important that the reduction is more successful with history of less than 24 hours of presentation. So this indicates that the early diagnosis is essential and dramatically improve the clinical outcome. Principles of the air reduction is the same like hydrostatic, catheter placed in the rectum and the anus occluded by stripping the buttocks tightly together or by gripping the buttocks between the fingers, catheter connected to the device or the system that can deliver air at a constant pressure with a safety device to prevent pressure suddenly exceeding that set by the operator. The question now is, what is the safest pressure to inject? What is the safest pressure, air pressure? Very important question. Yes, maximum safe air pressure is about 80 millimeter mercury in a young infant and up to 110 to 120 for older infant. The British Society of the Pediatric Radiologists in 2003 published a guidelines for safe practice of air reduction in it, that the maximum pressures is 120 with an initial trial at the pressures of 60 to 80, maximum of 3 trials with each sustained trial lasting up to 3 minutes, as long as the child remains stable. If the child condition deteriorate or become unstable, you must stop the procedure and the injection. Air is slowly introduced under the fluoroscopic guidance to allow the visualization of the head of intussusception and prevent it being missed if the reduction is going very rapid. Reduction is achieved with the air flow freely into the small bowel. The procedure is immediately terminated if the perforation happens. Air is seen track along the side of intussusceptum. Air dissecting sign as the reduction will be unsuccessful. This means that reduction will be unsuccessful if the air is seen tracking on the side of the intussusceptum. So it's very important that the procedure is stopped immediately. After successful air reduction, the child should be observed for 24 hours, initially keep nil by mouth and on intravenous fluids. However, numerous recent studies and pediatric surgeons document safe hospital discharge of some select patients after brief observation in the emergency department. Some important points, very important. Number 1, what about the use of sedation? Is it better to perform the procedure of air reduction or contrast reduction in a sedated versus unsedated child? The procedure is often distressing for the child and for the parent if they are present in the room. However, it is still debatable to use sedation or not. Whether to sedate the child, give the child some sedation, or leave the child without any sedation. There is pros and cons for each of these. Number 1, in unsedated child, Valsalva maneuver, when the child cries, will rise the intra-abdominal pressure, and this may help the reduction. Number 2, Valsalva maneuver may provide protective effect against perforation because the external abdominal pressure decreases the transmural gradient. So there is a balance between intraluminal pressure and the Valsalva reduced when the child cries. Also, any sudden deterioration in the child clinical condition is more likely to be detected in unsedated child. So when you give a sedation for the child, you will relieve the distress. You will help to relieve the distress from the procedure. And you will stop the child being crying. However, if you perform the procedure without sedation, you will take these 3 benefits. Number 1, this rise in the intra-abdominal pressure with Valsalva and child crying will assist you during the reduction. Number 2, this increased pressure will make a balance between the pressure inside you inject and between the abdominal pressure. And also any sudden deterioration in the child clinical condition more likely to be detected in unsedated child versus sedated child. So it's better to perform the procedure without sedation. It's very essential point. Number 2, incomplete reduction. If you have an intussusception that reduced as far as to the ileocecal valve, but not through it, what to do? Number 1, it's now important at this point to allow the child to rest for a few hours as the edema, as we said, at the ileocecal valve may resolve and further reduction trial can be made to avoid the need for surgery. This is number 1. Number 2, second trial can be made after 4 to 6 hours if the child is stable and the intussusception has been partially reduced on the first trial. So if you face an incomplete reduction, we mean that the intussusception reduced as far the ileocecal valve, but not through it. Still present part of the partial intussusception. What to do? Wait and leave the child to rest. The edema of the ileocecal may resolve, and further reduction trial can be more easy, avoid the need of the surgery. After 4 to 6 hours, you can perform second trial, provided that the child is stable and the intussusception partially reduced during your first trial. If there is no progress, then the child should proceed to surgical reduction, yes. However, the reported rates reaching about 80% reduction success suggests that this is maybe important to wait and to try a second trial. Success rate varies between the center. However, the guidelines suggest that at least 70% should be achievable of success rate during this, using this technique for incomplete reduction. Perforation. If there is a tension, pneumoperitoneum, rates typically less than 2%, with the most recent publication citing an average rate of 0.8%. Parents should be informed that significant pneumoperitoneum would require immediate decompression and immediate surgical intervention. Parent must be informed that if significant pneumoperitoneum happen, this will require immediate decompression to save the life of the baby and also may require immediate surgical intervention. It's very important. Perforation or tension pneumoperitoneum. The question now is that air reduction perforation. We mean that perforation happens during air reduction of intussusception. Usually doesn't result in widespread contamination. Why? Because number one, the large bowel is usually empty of stool. The child is obstructed. Number two, air escapes and rise up to the top of the abdomen rather than washing the contaminated content within the abdomen, as if perforation occurs with fluid. So the air is better here also because it will escape and rise up under the diaphragm. So not washing the contaminated material will not lead to widespread contamination. Number three, perforation most likely to secondary to bowel necrosis and not excessive pressure. So if perforation occurs during air reduction, don't worry, as this perforation usually doesn't result in widespread contamination. As the large bowel is usually empty of stool, the air escapes and rises to the top of the abdomen rather than the fluid do. Also, perforation most likely secondary to ischemic bowel in the intussusception rather than using severe excessive pressure. What the treatment of the tension pneumoperitoneum? Number one, immediate stoppage of the procedure. Number two, immediate release of the pneumoperitoneum to avoid embarrassment of the action on the diaphragm and to avoid cardiac arrest. So stabilize the patient using whether needles or angiocatheter above or below the diaphragm, followed by immediate operative exploration. Very essential. Unsuccessful reduction. What to do? Second attempt can be started 13 minutes to 24 hours after the initial attempt, may be done on the OR prior to the laparoscopy or on conjugation with laparoscopic reduction. So you can try, before you introduce the laparoscopy, second trial with air reduction. Pre-medication with midazolam may increase the chance of successful reduction in some cases. So what to do with unsuccessful reduction or failed reduction? You can perform second trial after 30 minutes to 24 hours after the initial attempt or trial you can perform this second trial on the operating room itself prior to introduce the laparoscopy. Risk of recurrence. Recurrence of intussusception, yes, there is a risk, and the parent should be informed about the risk of recurrence over the next few days after initial reduction. And parent must be informed about the warning signs that should require urgent return to the hospital. There is a possibility of recurrence of 5 to 10% in the first 72 hours. Any clinical appearance of abdominal pain after reduction could be sign of ischemic bowel or recurrent intussusception, and repeated ultrasound is needed. So there is a risk of recurrence after successful reduction, yes, and you must inform the parent about this risk, and parent must be worried that any abdominal pain after reduction may be sign of ischemic bowel present inside, or may be sign of reduction of recurrent intussusception, and ultrasound is needed, and early return to the hospital is needed in such cases. Regarding operative reduction, what is the indication? Number one, if there is a sign of the shock or peritonitis at initial examination, or atypical presentation of or features of secondary causes. Also, if perforation happened during radiological reduction, or there is a failure of radiological reduction. All these are indication for operative intervention. Preoperative preparations arrangement should allow for emergency surgery in all infants undergoing trials of radiological reduction to minimize delay. As we said, that the pediatric surgeon and the team must be ready and available in the center performing radiological reduction of intussusception. It's very important in all hospitals perform radiological reductions that the pediatric surgery team must be standby for any complication to avoid any delay. Preoperative preparation includes intravenous fluid resuscitation, administration of broad-spectrum antibiotics, nasogastric tube for decompression, and insertion of urinary catheter. We may have open surgical reduction or laparoscopic reduction. Regarding open surgical reduction, usually we choose right lower quadrant incision, whether above or below the umbilicus, as the commonest site of intussusception is at the ileocecal valve, and the cecum is mobile, and the bowel can be easily mobilized from there, even if intussusception has progressed further to the rectosigmoid area. So the right lower quadrant incision, muscle splitting incisions, is preferred one. It's important to evaluate the extent of the intussusception before delivering it. As in severe cases, it can be extended into the rectosigmoid region, which usually require extension of the incision. Sample of the peritoneal fluid may be sent for the microbiological analysis. So it's very important after the incision to assess the extent, starting point and the ending point of intussusception, as you may need to prolong or extend the incision. Bowel should be gently manipulated and pushing rather than pulling. You must push, not pull, involved in the intussusception. However, care should be taken if reduction is difficult, as too much handling may cause serosal tears or perforation. So please be very patient and please be very gentle when manipulating the bowel, not to be very aggressive, as there is maybe serosal injuries or tears or even perforation. Bowel should be palpated. It's very important for all pediatric surgeons that the bowel should be palpated to rule out pathological leading point, bearing in mind that edematous ileocecal valve or Peyer's patches can mimic an intraluminal mass. This task may be more challenging for the pediatric surgeon to exclude the presence of pathological or anatomical lead point, mass, tumor, Meckel's, appendix, duplication, carcinoid, polyp. There may be anything which is the cause. If you miss this, the intussusception will recur. Careful palpation is essential, particularly in the typical infant age group. The most common finding is a dimple at the site of the Peyer's patches or edematous ileocecal. Mickels must be resected if present and the cause at this point of surgery. So the palpation is very essential to exclude the presence of secondary causes or the leading point. Once the leading edge of the intussusceptum is identified like this by arrow, it's gently manipulated back toward the normal position. Excessive force or pulling is avoided to prevent injury or perforation of the bowel. Just pushing, gentle pushing. Reduction of the ileum through the ileocecal require patience. 4 fingers and thumb are used to 4 fingers and thumb used to push the apex of the intussusception gently while pulling back the cecal wall. You push using 4 fingers and thumb. Very important technique during reduction. Resection will be necessary if the intussusception cannot be reduced. This is number 1. If there is necrotic or compromised bowel, if there is a pathological lead point, you may need to perform limited resection. The intussusception should be reduced as far as possible to minimize the extent of any resection. This is usually segmental and rarely extend to formal right hemicolectomy. Questionable ischemic bowel can be warmed with a saline-soaked laparotomy pad and re-evaluated. It's very important for the pediatric surgeon to be very patient, very quiet during this reduction of intussusception, searching well for the presence of pathological or secondary causes. Primary anastomosis is almost always possible and performed with single layers of interrupted extramucosal sutures with the knot placed on the serosal surface. Any mesenteric defect is closed in similar fashion. The need for rapid surgery may be mandatory in very thick infant with a doubt about the viability of the resection margin may require the formation of a stoma. If you are doubt about the viability, you need to perform surgery very rapid. You don't have a time to soak or to put hot fomentation. You may need to perform a stoma to save the baby life, depending on the anesthesia, also circumstances. Stoma closure performed when the infant condition improve and the stoma are healthy, it may be possible to oversaw the perforation using interrupted extramucosal suture, provided the edges are clean and viable. You can oversaw the perforation if the edges are clean and viable. If intussusception is extensive beyond the splenic flexure, consideration should be given to examination of the DG. Flexure 4, coexisting malrotation. We speak about WAS syndrome, association between malrotation and intussusception. If present, formal lab procedure should be performed. In the presence of the transverse incision, if you decide to perform transverse incision below the umbilicus, it's acceptable to perform an incidental appendectomy, provided that the cecal wall is good to avoid the confusion in the future, as the patient will have a right lower quadrant scar. So the patient will have lower quadrant scar, so we must perform appendectomy. So if this patient complain in the future from symptoms of acute appendicitis with this scar, there will be misleading for the surgeon that there is removed the appendix or not previously. So please, if you choose to open this incision, you must perform an incidental appendectomy, provided that the cecal wall is good and allow for this procedure. Ileobexy, this is controversial, described in some patients with recurrent intussusception after operative reduction, is to fix or to perform what's called ileobexy or ileocecobexy. However, in large series, this technique was not shown to reduce the re-intussusception rate when compared with operative reduction and resection of the affected area. So there is still a debate and no conclusion yet about to perform ileopexy or ileocecopexy or not. Laparoscopic reduction. Yes, initially the use of the laparoscopy was only diagnostic, used in children with equivocal radiological studies associated with high conversion rate, reaching about 70%. However, recently or today, laparoscopic approaches become the initial operation of choice in many centers. Potential advantage of laparoscopy, all of us know that it improves the post-operative pain, shorter hospital stay, ability to diagnose full reduction when this is unclear after pneumatic reduction, thus avoiding laparotomy or recurrence. So it will give an overview of the whole abdomen, avoid the trauma of the open axis, and significantly reduce the risk of intraperitoneal adhesions. Yes. Contraindication to laparoscopy is a hemodynamic instability, peritonitis or evidence of pneumoperitoneum, severe bowel distension that limit visualization. And this is very important limitation. In case of intussusception with obstruction, intestinal obstruction, there is many dilated loops. So laparoscopy may be very difficult to assess and to get a space inside. So if there is severe bowel distension that limit visualization, laparoscopy is contraindicated, and you may need to perform an open access or open surgery. Conversion. Regarding conversion to open procedure, the reported rate variables from 12 to 40%, but most reports speak about 30% with a low overall complication. The risk factor, including intussusceptum extending beyond the ascending colon, as well as of presence of the known pathological lead points. This may lead to conversion. If the bowel reduced to the point at which there is a dusky appearing bowel or more serosal tear, you may need to perform assisted laparoscopy or to convert to open procedure. If the resection is required, this is often performed by extruising the bowel through the periumbilical incision. If this is not possible, the operation is converted to laparotomy. Retrospective analysis of about 65 cases found that in patients unable to be reduced laparoscopically, 33 had a lead point that require conversion to open. So if we cannot complete the reduction using laparoscopy, about 33 of these 65 cases had a lead point that require conversion to open procedure. Some principles of the laparoscopic reductions, we use 3 abdominal boards, 1 infraumbilical for the camera and 2 others, Plant grasper and Powell clamp. Attention initially focused to the right iliac fossa, as the commonest type is ileocolic type. Gentle pressure is applied distal to intussusceptum using a traumatic grasper. Traction here is allowed, unlike open technique. In open technique, we push and never tract. However, here, usually traction is required proximal to the intussusception to complete the reduction. This is against or unlike the rule in the open reduction. Excessive force should be avoided, and careful inspection of the bowel is performed to evaluate any signs of ischemia or bowel necrosis. Appendectomy is not routinely performed unless it is felt to be the head or the leading point, as there is no scar in the right iliac fossa, unlike open surgery, because the presence of the scar will need to perform incidental appendectomy. However, here it is not removed unless felt to be the leading point for the intussusception. The criticism of the laparoscopic reduction is the loss of the tactile sensation that may lead to missed pathology. This lack of the tactile sensation seems very important related to the leading point and should be remembered. And the consideration given to the delivering the small bowel through the umbilical port after successful reduction, especially in older children. So unlike open surgery, in open surgery, you will palpate the intestine searching for leading point, polyp, something abnormal in the intestinal wall. This lack of the tactile sensation must be remembered for the laparoscopic surgeon, and you may need to deliver the small bowel through the umbilical board after successful reduction, especially in older children, and palpate the intestine for detection of any leading cause of intussusception. Regarding post-operative care, usually post-operative management depends on the extent of the disease, the surgical procedure performed, the overall condition of the child. In uncomplicated cases of non-surgical reduction, enteral feeding should be started as soon as anesthesia allows for it. Some authors even recommend outpatient management. On the other side, in the complex cases, short-term nasogastric tube and parenteral nutrition should be started until the edema of the bowel wall has disappeared and the bowel function recovered. Routine follow-up ultrasound in asymptomatic patient may not be necessary. However, once the infant becomes symptomatic again, it must be re-evaluated immediately. The last point is to speak about special types of intussusception. We speak about the usual types, the primary intussusception or idiopathic and secondary intussusception. Now we will speak about what's called recurrent intussusception. And we speak about post-operative intussusception and chronic intussusception. Recurrent intussusception usually described after non-operative intervention in about 10% of cases, 1/3 occurring within 24 hours and others up to 6 months of initial episode. Number 2, after operative reduction or resection, however, this is least likely. Number 3, after laparoscopic reduction, lack of the tactile sensation, maybe there is maybe leading cause or secondary cause missed, as high as 10%, although the recent review showing much less rate of 4%. When this occurs, it is reasonably to try a reduction again. Diagnosis, usually diagnosed earlier in the course of the disease because the patient becomes more familiar with the symptoms and the presentation. Concern in such cases of the recurrent intussusception is for occult malignancy. Unfortunately, clinical finding or pattern of recurrence don't predict the presence of malignant lead point, and radiological reduction and follow-up ultrasound recommended to look for occult pathology. So the recurrent intussusception we must put the concern of occult malignancy that may be the lead point for this intussusception. However, unfortunately or badly, the presentation or the pattern of the recurrence don't predict or don't point to the presence of the malignant lead point. Treatment of recurrent intussusception, first, non-operative approach. This is the initial management, provided that the patient is not toxic, not showing signs of peritonitis or hemodynamic instability. Enema reduction success rate after one recurrence comparable to those with the first episode, and better if the child didn't previously require operative reduction. Surgical approach for recurrent intussusception may be more important in recurrence to identify and treat pathologically lead point or occult malignancy. The role of ileopexy again and ileocecal in the cases of multiple recurrence remain a matter of discussion, and conclusive data for one strategy is not available yet. Follow-up imaging for recurrent intussusception should be delayed until the expected swelling and the potential reactive lymphadenopathy associated with intussusception has resolved. This is the first special type, is the recurrent intussusception after reduction. Post-operative intussusception. It's a rare clinical entity described after ileocolic intussusception reduction and resection, retroperitoneal dissection, long intra-abdominal procedures, lead band, extra-abdominal operations. There is maybe called post-operative intussusception related to these surgeries. Account for about 3 to 10% of cases of the post-operative bowel obstruction, and mostly occur in the initial 10 days following the procedure. Ileus and adhesive obstruction are more common. Causes of the bowel obstruction, yes. Ileus and adhesive bowel obstruction are the most common causes of post-operative bowel obstruction. Thus, a pediatric surgeon must think about the post-operative intussusception as a cause and use ultrasound for diagnosis. Most post-operative intussusception are ileoileal and respond to operative reductions without resection. There is a third one called chronic intussusception. It's a rare condition defined as non-strangulating, long-lasting intussusception of minimum of about 14 days, mostly due to anatomical leading point, manifested by the chronic diarrhea resistant to any therapy. Patient usually passing bloody or mucus stool and suffer from colicky abdominal pain with episode of vomiting and finally may lead to weight loss. The diagnosis can be confirmed by the ultrasound, contrast studies, or even laparoscopy, and the treatment is similar to acute intussusception. In conclusion, pediatric intussusception represents the most common abdominal emergency in infancy and early childhood, with overall incidence of about 1 to 4%. Management requires teamwork of the pediatrician, pediatric radiologist, pediatric surgeon. Overall prognosis is excellent if the best practice standards are followed with early diagnosis. Efficacy of the treatment with whether radiological or surgical reduction depends on the timing of the presentation, type of intussusception, ileocolic versus small bowel, presence of pathological lead point, ultrasound, Doppler finding, and presence of the expertise in the reduction techniques. So our topic today is very important for all pediatric surgeon and the pediatrician. We speak about intussusception is one of the most common causes of bowel obstruction in infancy and early childhood. Intussusception may be primary or idiopathic with no cause. Why these bowels telescope in each other? There are some theories. There is maybe infectious etiology, which is a very common. There is maybe anatomical or abnormal structural abnormalities in the cecal wall, maybe altered peristalsis, maybe some neurological disorders. And on the other hand, secondary intussusception. Secondary intussusception, yes, related to the presence of anatomical or pathological lead points. These secondary intussusception may be related to Michel's, appendix, carcinoid, may be related to polyps, duplications, may be malignant, like lymphomas, may be systemic diseases, like cystic fibrosis, some types of purpura, may be related to association with malrotation, WA syndrome, association between malrotation and intussusception. Pediatric surgeon must think about all these types, especially if the child present outside the normal range of age for the primary intussusception. It's very important and very essential. Diagnosis essentially clinical with a triad: abdominal pain, abdominal mass, passage of the red currant jelly stool, manifestation of bowel obstruction. Ultrasound is the gold standard for the diagnosis. May show the target sign, may show the pseudo-kidney sign, or may show free fluid between the two parts of the intussusception. The management starts with resuscitation, depending on the presentation. Present with severe case or early or late diagnosis, followed by reduction. We start and all centers perform radiological guided reduction with air reduction technique. However, pediatric surgeon and team must be available and standby in case there is a complication so they can interfere to avoid delay in the management. Air reduction is reported and there is many papers describing the success rate of the technique. The pressure is limited by the guides documented by the British radiologist for safe practice in 2003. There is an important point that use sedation or not during reduction, better not to use, as the crying and the valsalva performed by the child will help you during a reduction. Also, you will detect any deterioration in unsedated child. There is maybe questions related to if perforation happens, what to do? Immediate stoppage, immediate decompression. But don't worry that the perforation will not cause extensive contamination, as the air will go up and your colon of the baby is almost empty of stool. Unlike fluid, the air will go to the top of the abdomen. Incomplete reduction. The reduction go but stop at the ileocecal. Don't worry. Leave the baby to rest and retry again with a second trial, as the edema of the ileocecal may resolve and allow for the free air to go. Unsuccessful reduction, you can perform second attempt or second trial. Even you can perform the second trial in the OR, inside the operating room. It's very important, before introducing laparoscopy. Then we speak about the surgical. Surgical may be open or may be laparoscopic. Open technique or laparoscopic technique. Many centers today use laparoscopic reduction technique. However, open is still indicated due to the presence of the severe distension, the limited space for the laparoscopy. So we used to open in the presence of the perforations, in the presence of the contamination. Also, we speak about special types, like recurrent intussusception, post-operative intussusception, chronic intussusception. So this topic is very important for all pediatric surgeon and all pediatricians. Early diagnosis and early trial of reduction is a cornerstone. The presence of the child outside the age or the presence of the child older than the age range for the disease should raise the suspicion of the pediatric surgeon for the presence of pathological or anatomical lead point, may be the recurrence in intussusception related to occult malignancy. I think the presentation and the lecture is very important for all pediatric surgeons and pediatricians dealing with children concerning one of the most common cause of bowel obstruction in infant and children. Thank you very much for watching and see you next in next subject of pediatric surgery made easy. Thank you very much.